Welcome to The Whole Pineapple. I'm Ruby Boris.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. We'll talk with experts on a wide range of topics, including nutrition, stress relief, sleep, mental health, etc.
And we'll dig into the issues that can cause fertility challenges, like PCOS, or early menopause, or cancer treatment.
So if you're curious about your fertility, whether you're ready to start a family,
or you're preserving your options for the future, let's dig in. Hey fam, we're back for another episode of The Whole Pineapple. And if you're new here or you don't know our voices by now, I'm Ruby Boris.
I'm Ann Judge,
my beautiful co-host. And we have a very important topic to discuss today. So I think we should really just dive in because there are so many facets and nuances to the conversation that I want to make sure that we touch on all the things that we want to. So Jasmine Johnson is a physician and assistant professor of obstetrics and gynecology in the Division of Maternal Fetal Medicine at Indiana University School of Medicine. She founded the blog The Mrs. the Mommy the MD in 2010, and you might know her as Mrs. Mommy MD on Instagram. Her research interests include health disparities with the obstetric population and quality improvement to reduce maternal mortality and morbidity. She is a fierce advocate for improving equity and eliminating disparities in obstetrics and gynecology and healthcare as a whole. Thank you so much for being with us.
Thanks so much for having me.
Was that good? Is there anything else you want me to add in there?
No, that was perfect.
Okay.
That's fine. That's a lot of words. Every time I hear someone do an introduction, I'm like, wow, there's got to be an acronym or something to just let everyone know all the things.
Yeah, just like here, just click here if you want to read all of my things. Well, thank you so much for being here. Yeah.
Oh, yeah. Your talk at the symposium was amazing to be able to cover so much in such a short amount of time. And I wish we had more time today.
I know
we're going to probably still have more things we want to talk about when we're done, but I really appreciate you being here to share everything that you've been learning and working on with us today.
Well, yeah, I'm excited to get to it. This could be an hour-long conversation or more. So
I think usually we just kind of start off by asking about your background, like what drew you to medicine and in this field, and then especially what kind of drove your interest into the disparities in healthcare.
My dad's a physician, so that was my earliest introduction to medicine. I would tag along with him when he would go around on the weekends and just like sit in the nurse's station and eat all the crackers. But
there's always snacks at the nurse's station.
Right. Always the snacks. And, seeing how medicine was such an integral part of our lives growing up, and that my dad was like one of a few specialty physicians in our community. And so everyone knew him and they always had wonderful things to say about how he changed their life. And so I kind of knew I wanted to go into medicine. And when I went to college, I was at the University of Michigan and I got introduced to health disparities. And first it was just doing like a volunteer organization where we were really focusing on like educational gaps and disparities. And then I realized, hey, like this crosses over into medicine too. And I thought I was going to move forward with public health. But of course, being the nerd that I am, I was like, I just love being around patients and like the problem solving of clinical medicine. And my own pregnancies, my experiences were very different. And I talk about this in my blog, but my first child I had my last year of college. It was a surprise pregnancy. It definitely was not in the plan as someone who thought they were just going to head on to medical school and go the traditional route. I was on Medicaid insurance kind of on my own during that time, navigating the healthcare system, getting my college education, but still feeling very overwhelmed and unsupported as a Black single mom at the time. My physician was amazing. And so I always tell people that my pregnancy was low risk, but socially I was high risk. And those social determinants of health that we all talk about, it was for the first time in my life that I experienced those things. If you can imagine someone being a child of a physician, there was a lot of privilege in my life up until that time. Even though I delivered at, in a low income neighborhood in Detroit at like a county hospital, I had a phenomenal delivery experience. I had awesome labor and delivery nurses. My doctor was great. And I just knew that I wanted to be that for someone else. And when I started residency, I was touched by having a patient she died after having her baby. Despite doing everything we could with an awesome multidisciplinary team, we still couldn't save that mom. And she was a young Black woman. And so that kind of started the cascade of me asking questions about how do we look at all of these cases? How are we doing as an institution? How does that compare to the country? And you can just kind of dive right in and you see that there are so many gaps. And this has been such a longstanding problem. And it really has been a journey for me personally, but also professionally, to be able to blend those two things.
This is not a new problem, as you say. And I've heard a few like NPR newscasts about maternal mortality and Black people with uteruses. Like, get us up to speed on stats.
You know, the one like attention grabbing statistic everyone talks about is that the United States has the highest maternal mortality rate of developed countries. Despite all the money that we spend on healthcare, we still lose 700 to 800 birthing people every year to pregnancy related causes.
That is crazy. That is such a huge number. I mean, every time you hear it, it still doesn't lose its ability to shock you.
It's heartbreaking. And then when you look at disaggregated data, or when you break things down by race, and I always talk about, we can't see a problem if we don't measure it, if we don't look at things by race and ethnicity. You'll see that Black birthing people have a maternal mortality rate that's 3 to 4 times that of white birthing people. And then when you look at like social determinants of health and those factors, so in research, we like to say that there are like things that can protect you from a bad outcome and things that can make you more at risk for that. And what we know now is that things that protect white patients actually don't protect Black patients in the same way, and other patients of color. In particular, the maternal mortality rate for a Black person that graduated college is higher than that of a white person that didn't finish high school. And so when we get it, you know, people criticize the disparity and say, well, we're not telling the whole story. You know, Black people live in poverty and they're not getting prenatal care. That's not true. There's so many stories of Black patients who have done everything right, in quotes, and still have these terrible outcomes. And so we need to dig a little deeper.
And how did you balance, I mean, everything going on in your life, finishing your residency, then getting into maternal food and medicine, while also being a mom and still having the time to even do this? Like, it seems like it'd be really easy to just kind of bury your head and be like, well, I'm not going to think about disparities. That's not my issue. I didn't go the public health path. I'm just focusing on clinical care. Like, how did you decide to still keep this as an ongoing interest for you?
Thank you for asking about that, because I feel like this is such a heavy topic. And one of the things that I love about my social media is that I'm able to talk about everything. So I talk about the research, but I also really like showing our life behind the scenes and like the things that me and my kids are doing.
Yeah.
And I would say it really helps to have a village. And so anybody who approaches me and is like, I want to do what you're doing, go to medical school with, you know, already having started my family, or I want kids one day. It's really important to have support, and that can either be a partner or just an extended network, you know, throughout school. My husband has been like my number one support person throughout this time. We definitely don't have those traditional roles in our house. Like, he was always the one taking the kids to school and updating the teachers and making dinner. And that works for us. It's such a blessing. And then like our families also would like take my kids for a week while I was studying for exams, or if, you know, I wasn't able to have a vacation and they had an extended vacation from school. And it really has been the efforts of many to get me here. And also, I would say, just give yourself grace. So those people who are like, how do you balance it all? There's no balance. It's about integration. Like, once you let that go, you know, some days I feel like I'm killing it. Some days, like you said, I'm like, I just want to bury my head in the sand. I just want to do my job and go home. Some days are really hard.
Yeah.
Some days you're like really functioning. I like to like think of myself as the Beyonce of MFM.
You are.
Thank you. Sometimes I feel like I'm there, sometimes not so much, but you gotta just roll with the punches. And if you're doing your best, that's all that matters.
And it is something that we really should talk about more. You know, I had a new patient just this week that's talking about freezing her eggs, even though she's only in her late 20s. And I'm kind of asking why. It's like, well, I'm going to med school next year and I've got this pledge. She's like, so just realistically, I'm probably not going to try until I'm in my mid 30s and I want 2 or 3 kids. And I was like, actually, yeah, you're totally right. Let's do this. But
it's so smart.
Because you're right. You can't do it all by yourself. You need to have support, and not everybody has family systems or people that can be there for them. But it's really great to see that you've been able to put this team together and accomplish so much.
Thank you. And also, in 2010, no one was talking about how they were going to medical school with a toddler. But that doesn't mean it wasn't happening. People just weren't as visible. And I'm glad that, you know, social media has its weaknesses, but I'm also glad that it allows some visibility for like people that aren't doing the straight through college, straight to med school type path, because there's so many of us. And I realized when I got there that there are a lot of parents in medical school, a lot of people who do non-traditional things. And I think it makes you better for it. I think it really does bring a perspective that everybody doesn't have.
Yeah, I had a classmate in school who had a baby at the beginning of our graduate program and then was pregnant at the end of the graduate program. She was the Beyonce of our family nurse practitioner program. She was amazing.
I love it.
But, like she seemed like she had, I'm like, how do you have everything together? I'm doing the same thing that you're doing, but you're doing everything with on top of that with children. I'm like, I don't even know.
Well, I know for me, like when I went back to school for my nurse practitioner program, having the 2 little kids, I mean, I think about how much more efficient I was than when I was in school the first time.
That's such a good point.
There's no time to waste. There's no procrastination. It's like, this is my hour I have set aside to work on this paper. So I'm going to get this paper done and then I'm going to focus on other things. Like it does in many ways make you a much more focused person, able to prioritize. And that's what you need to be a good care provider too.
For sure. Now that my kids are older and don't really need me to like surveillance them as much, I feel like I'm less efficient because I'm like, oh, no one needs me. I have more unstructured time. So you're absolutely right.
Maybe I will check social media a little bit more and see what's going
on.
Well, on social media, I just got an ad today that it was for some clothing company and it was for mature women of age or something like that. And I was like, excuse me, Mark Zuckerberg? Mature women of age, pardon me?
No, my friends and I joke that we're very full Costa Grandma vibe. That's definitely my aesthetic. But I see all the ads for like the nice flowy shawls. I was like, that does look nice though. That looks cozy. Like that's definitely more than I don't need the bikini ads. I like the cozy layers.
That is so funny.
I'm like, I told my husband about it and he's like, well, yeah, your name is Ruby. You buy Sensodyne toothpaste and like your primary Spotify is like Fleetwood Mac. Like, of course.
Okay.
Like, hey, Fleetwood Mac still rocks. Okay.
We are not mature quite yet.
But I think also having children, you're so much more motivated because you want to be able to set that good example for them too. My mother-in-law, she is a radiologist and she has 5 kids and she had my husband when she was in medical school and she has all these great stories about leaving him at the nursing station because her daycare fell through and she just had to get this done.
Right.
And, but I mean, she set that example for her kids and she's someone in Texas that had a bunch of sons and they married everyone that they married is also working and a professional. And I think it sets this example that there are different roles for how you can be a mom. And it's really cute because some of the grandkids call her Dr. Grandma.
Cute.
And so they have like grandma on one side and Dr. Grandma on the other side.
That's adorable.
Yeah, note to self, I want to be Dr. Grandma in the future.
Yeah.
That's awesome.
That's awesome.
But you want to show this next generation, all the different things that you can accomplish.
That is so cool.
Well, I know we're getting off topic for the disparities, but tell me, it's just so fun to talk to you.
Okay.
So, you're in an MFM practice and then all this research that you're doing, is that as part of like fellowships, grants, or is this more just on your own time? You're also still advocating?
So I just finished fellowship last summer and I've started this new faculty position through the School of Medicine. And so I see patients. That's like my main split of time. So I'm clinical in the office. Typically MFM, we do a lot of outpatient stuff. So we read ultrasounds and do like sometimes preconception consultations, sometimes like prenatal care consults. And some of us do like full spectrum prenatal care. With the rest of my time, I have like some academic time and also research time allotment to me. So I'm not independently funded yet, but that's my goal in the next year. And so I've kind of continued the projects that I was doing as a fellow, making new connections at a new place and trying to get my own stuff off the ground. So that's like what I've been doing for the last 9 months since starting.
So tell our listeners a little bit about the projects you were doing before, because it was so interesting when you talked about it at the symposium.
Some of the big outcomes that we have good disparities data on in pregnancy are like preterm birth. Again, that's something that is more common in the United States, but specifically when you look at disaggregated data by race, Black birthing people have a higher preterm birth rate than everybody else. And that seems to be pretty consistent across all the states. And also preeclampsia or high blood pressure in pregnancy. So we looked at that stuff. And so particularly for the preterm birth project that I did later in fellowship, we looked at all of the like birth certificate data in the United States over a 2-year period, like 2015 to 2017. And we wanted to look at kind of how the ideal patient. And I put that in quotes similarly to earlier, because when we think about patients that should do well, they have private insurance, they have higher education. So we kind of created our own group of patients that were high socioeconomic status. So we looked at everyone who had private insurance, 16 years of education or more, and wasn't receiving like WIC benefits.
Not smoking cigarettes, normal body weight, kind of like all the like things that we try to.
Yeah, the things that like people try to explain away disparities
Right.
and say that like Black patients have all these risk factors. And so we try to make everybody equal, right, in the beginning. And what we saw is that the preterm birth rate still was highest for Black women, even in this high socioeconomic status group. It was lowest for white women. So we looked at those who were identifying as white, Black, and then multi-race or Black and white race. And there was this like intermediate effect if you identified as both Black and white. And I think it's important to highlight that race is this social construct, like it's not genetic. And when we think about why people of different races have different outcomes, one of the things is structural racism and how they interact with our country and the different domains in society, and how, you know, me being a Black woman, how my experience in healthcare may be very different from someone who isn't Black. And that could be because people have different biases about me and I receive different treatment, or I might just because of historical practices where like Black people weren't given home loans in certain neighborhoods that then became neighborhoods that didn't have good school systems, didn't have access to good food, didn't have access to hospitals. So then I'm presenting late and not having access to healthcare, those types of things. And so the socioeconomic status study was to just further debunk that myth that like, you know, if you do everything right, you shouldn't have the disparity. That's not true. Another really big study I was really proud of, we looked at patients who had a low risk cesarean delivery on our units over like a few years. We wanted to kind of investigate if there were differences in how patients were having their pain assessed after delivery, how they were reporting their pain, and then treatment. And so we actually saw that Black patients endorsed a severe pain score of 7 or more frequently, but they received less assessments by nursing staff and they received less pain medication, both NSAIDs and opiate medication. Again, you can't get at all the factors that contributed to that with just that one study, but it really is eye-opening when you're seeing data at your personal institution that says that there are racial differences going on. Like you need to investigate further. Northwestern had done a similar study. We were at UNC and they got the same outcome. So it wasn't just unique to our institution. And I also think if you had looked at institutions all over the country, you probably would have seen a similar thing. It's really interesting because when you think about pain, there's a lot of historical data that shows that, similar to us thinking about this not being a biologic thing, but like back in slavery times, you know, they said Black people didn't feel pain, enslaved Africans didn't feel pain, and that justified why medical experimentation was imposed upon them, why they were forced to, you know, live in such inhumane conditions. And so we even see studies today that show that people still feel like there are a biologic difference between Black and white people, and that it can impact how they could be treated in healthcare, you know, how they get pain medicine and how they're assessed. And so all of those things are so important. I think we think that medicine and health disparities exist in a silo, but it's all connected. It's all part of the bigger system with historical stuff, things that happen in the community. And so we just need to connect the dots.
I think in our first episode, we talk about the history and the physician who created the speculum, and he was deemed like the father of gynecology, but he was doing all of his like studies on enslaved African women and without anesthesia.
Yeah.
And then would take that information about how to treat, what was it, Anna?
Like fistulas and prolapse.
Yeah. So how to treat fistulas, and then took, you know, like, oh, this is how to perfect the practice, and then performed it with anesthesia with white patients.
Yep. I talked about that in my talk. And, you know, it's mind blowing when we hear all this discourse about like critical race theory and how we shouldn't have it in schools. Like, that is the only way that we're going to have these honest conversations about what's going on. I went through 4 years of OBGYN residency and no one told me about Marion Sims. It was like after I finished residency and was like reading about disparities and pain and all of these things, did like all of this come to light. And I'm just like, why are we not talking about this? Like, this is such a huge part of the specialty. And honestly, I think part of the reason why patients don't trust the medical establishment is because there are so many historical practices rooted in experimentation and racism and all of these things that are so harmful to non-white communities. We're not going to end disparities if we don't talk about this stuff.
And I wanted to know, what was the atmosphere like at your institution when you did the study? Because I feel like when you read about research, there's always that thought like, well, but our hospital's not like that. Like we assess paid equally.
Well, up here in the Pacific Northwest, we don't do that.
What was it like to do a study and show that no, our hospital has all these same issues?
We talked about it with a lot of humility. I think that was one of the things that I feel like is so cool about research and why I wanted it to continue to be a part of my work, because you can get these answers and it impacts how people practice and changing minds and changing hearts. And so, no one walks onto a unit and says, I'm not going to check on my Black patients. I would hope not. That, most people don't walk into a unit and say, I'm not going to check on my Black patients as frequently as my white patients, or I'm not going to give them pain medicine. No one says that, at least that I know or encountered at our institution. But I think that it helped us to think a little bit more about, well, what's contributing to that? Maybe, we know that nurses are overextended. Everybody in the healthcare team is. When you're strapped for time, we know that that's when biases surface the most, because we have these like algorithms in our head that give us shortcuts. And so what about our biases maybe impact how we function when we're crunched for time and when we're thinking about how we manage our workload and how we take care of patients? And so there are a lot of conversations and meetings after that. People were really upset that that was our data, which, sometimes you have to get through the hard part so that you can get to the good stuff, right? You can't fix what you don't measure. And I think that was the strength of that study, in that it was at our institution. So there was no denying it.
So then we can get the work done.
Mm-hmm. Yeah, I've never understood why some people seem so offended by the idea of implicit bias. It's like, shouldn't that be an easier thing to wrap your head around, that you're not consciously choosing to do? I think there's this like old school perception of what racism is, which is people that hold these beliefs that like people are in different status, and not realizing so many of these things are these just subconscious, as you said, mind making patterns and choices, and just not even realizing that you're doing things, but you're never.
And your past experiences in life and all of that. Yeah.
You're never going to realize if you're not at least understanding that it's there. And when you can do studies and have actual hard projected data, you think that would push people a little bit, but there's still so much defensiveness and anger, and you're saying I'm a racist and I'm not racist. And so I guess, talk a little bit about like how, as the field, we're trying to understand more about what we sometimes call like structural racism, and not focusing so much on individual people and individual choices.
So structural racism is going to be differential access to opportunities, experiences, resources related to like one's race or ethnicity. So when we think about structural racism, it's kind of those high level things that we talked about, like access to healthcare and food and a safe neighborhood. And so there is so much cool research going on where epidemiologists and public health people and clinicians like me are trying to connect birth outcomes like preterm birth, like preeclampsia, to structural measures of racism. Some good examples, there was a study that looked at neighborhood homogeneity. I always struggle to like say that, but basically like lack of diversity in your neighborhood in a city. And so we know that like redlining was this practice where they weren't giving home loans to Black families. So now today, the majority of Americans have their wealth in housing. But if Black families historically were denied loans, Black people don't have that wealth that white people do, or, that generational ability to like continue to acquire more resources. We know that in neighborhoods that are less diverse, and a lot of them have been tied to like historical redlining practices, you can still see those contemporary like patterns today of who lives there. There were higher rates of preterm birth compared to communities that were more diverse. And of course, like there's so many things that go into that. But I think like as we think about what those neighborhoods have compared to the more diverse neighborhoods and what's lacking, I think it could help direct policy.
And we're learning so much about like ACE scales and adverse childhood experiences, and how like things that happen even in toddlerhood like impact so many aspects of health as those children grow up. So and then you can get into epigenetics in terms of when people are pregnant and what are their stress and exposures and pollution levels and all of this stuff. So
it blows my mind sometimes, because like you don't even think about, like I did this like random project in fellowship where we were testing like amniotic fluid samples, and we were looking at like arsenic levels, which is so random. But in North Carolina, they have like an arsenic problem in the groundwater. It becomes a reproductive justice issue because if you have people living in communities where they are disproportionately exposed to toxins and not access to health creating opportunities, like it's just gonna compound the things that we see going on in the hospital. Another like structural racism type study, there was one that looked at incarceration rates in Detroit, and they saw that like when tax money was higher related to like prison expenditures, they had higher rates of preterm birth in those communities as well. So it's just very interesting. Yeah, right? Isn't that crazy? It's so interesting that we're able to connect these like non-healthcare things to health outcomes. And it just goes to show you like racism has tentacles in everything, and we have to like address it all in order to fix it.
Right. When we talk about racism in like maternal health care, like that's when you go in to have the baby, that's not the first time that you're suddenly like exposed to racism.
Right. Exactly.
Just in this like conversation, we brought up so many different areas that it can show up, and it's literally like every facet of our lives. So how do you not get overwhelmed? And like, where do we even start? You know,
yeah, if
like,
we're not able to redo all of our housing loan policies in the past, like where do you start?
Well, especially if we can't even talk about it, you know, I think maybe first step is to talk about it and in schools. Yeah.
I guess what did they do in your hospital after your study? Like after this, what did they actually do in terms of concrete changes, and how do you change your policies for pain assessments, or what was the action that actually came out of all of that?
Plan, do, study, act.
Yeah, so there's actually a follow-up study that's going to come out soon. But in the time since that data was collected, they actually introduced standardized order sets. So at the time when that study was done, everybody could just kind of order the pain medicine plan for their patient that they wanted. And so, you know, in a teaching hospital, you have residents, you have attendings, we had midwifery, family medicine. So everybody was kind of doing their own thing. And then it was more standardized. So hopefully this follow-up study will show that maybe there was less of a disparity in some of those instances. But then also we had good conversations about implicit bias, and we highlighted the Black-white differences in that study, but we also collected data on patients who were Hispanic and Asian. And then we're not doing a good job of like disaggregating even further. And that is like one of the things that I hope to do better at. But there were disparities amongst all non-white groups. And so thinking about interpreter services access, maybe people aren't getting checked on because there's a language barrier. Thinking about cultural humility and like what patients bring to their postpartum encounter as like their coping mechanisms for pain, and thinking about like, how do we decide what adequate pain management is? You know, maybe patients refuse medication and that's fine. Maybe they had other modalities that were helpful to them. And so there's a lot that we need to follow up and study. But I think the big things that we talked about that were like actionable was just thinking about like implicit bias on the staff side of things, making sure that patients felt heard. So if someone had severe pain, that it was addressed in a timely fashion, and then it was followed up to make sure that patients felt that they were adequately treated and listened to. Because a lot of the maternal mortality stuff and morbidity or bad outcome data, a common thread is that patients don't feel listened to. And so that was huge.
But we've tossed the term around a few times. Like, how would you define implicit bias if you're trying to explain it to somebody?
I was in a talk yesterday and there was this like great analogy. So
Excellent. I love analogies.
Yeah. Implicit bias, like I think of it as like a memory shortcut. Like it's something that you do without thinking based on like your previous experience or something you've been taught. And so this example, and I love it because it's like not race related, but if you had like two fires in front of you, and one was like a blue flame, like it was just like a totally blue fireplace. And then like the other one was like our traditional like red flame fire. Like it looks like the fires we recognize. And you're coming in from like the rain and you're really cold. Which fireplace do you choose to go in front of? And so some people might say, well, I've never seen a blue fireplace. Like that can't be warm. Like that's not a real fire. And so they go to the red. Or someone might say, oh, I've actually like never seen a blue fireplace. That looks really cool. And I'm going to try it and see what happens. Or some people might say, well, I've been in front of a red fireplace before and it worked for me. So I'm going to keep going to that one. So like even that, like in the most like basic example, like there are biases at play, whether it's, you've never seen a blue fireplace. If you want to like substitute that with like, you've never been around Black people or you've never, people always say, well, I have a Black friend. If you've never had a Black friend and you've never had the opportunity to like have a real conversation about cultural differences, then that seems unfamiliar and dangerous to you, or something that you just are adverse to. And so it may not be that you've actually had a bad experience with a blue fireplace.
Or even just not wanting to mess it up. Like, oh, I don't want to do anything wrong, so I'm just going to stay away from that.
Yeah. So that's how I think of implicit bias. And I was excited to get that analogy. So I'm glad I got to use it again.
I really like that analogy. Great.
But I feel like in my school too, they always talked about the things that we in healthcare can learn when we look at other industries, like specifically like the air traffic industry, and how once you have disasters, they kind of realize how bad humans are at like making split-second decisions, because you just fall back on your past experience.
Instinct.
You fall back off on whatever might have worked for you in the past, and that opens people up to stereotypes, implicit bias. And that's why they've gone so much to like checklist models, like get rid of hierarchies. Everybody goes down the checklist together, so you don't have to worry about the person who's in the jump seat not contradicting the pilot to be like, wait, isn't this happening instead? And I feel like they're trying to do more of that in healthcare. I know California had a lot of success with their toolkit model for trying to reduce preeclampsia, to just be like, here are the steps we do for everybody. Here are when we notice this for everybody, we don't brush off the blood pressure and think, well, this is probably because I've seen other patients before. She's just stressed out because she says she's in pain, but that's how dramatic people can be. And, just kind of take it out of people's thoughts and make it more like you are going down your little checklist and that's what you do, because we can't trust our brains to always, do the best for everybody that's coming before us.
Yeah. Especially now, we know it seems like there are just few and few resources for people who deliver healthcare in this country. And we're tired, and it seems like our patient volumes are getting higher, and having protocols, granted, like we still need to independently think and like see the patient in front of us as an individual, but it absolutely has been shown to reduce some of the most common causes of maternal mortality, hypertension and hemorrhage, because those are the things that like, it's hardcore facts. You can't dispute a blood pressure. You're exactly right. And we shouldn't excuse it away because someone's stressed or they were on the phone and they were upset. And hemorrhage, you lose the blood or you don't. And so it should trigger you to like do the same thing every time. And it has been life-saving.
I know. I'm trying to think. There's so many things I could.
I know. My brain is going a lot of places.
This really took a direction I didn't expect. Like, this is great, you guys.
This is so fun. I guess that kind of goes from that, like, talking about how we're trying to make improvements. What do you think has happened with the pandemic? I mean, do you feel like that just pushed us backwards? I mean, I think in some ways it's making healthcare systems open up to new ways of thinking and maybe new models and awareness of telemedicine and being able to treat people in underserved areas via telemedicine. So what are kind of your thoughts about how the pandemic might be hurting or helping this change?
And I agree. I think it's pushed us to think outside of the traditional models of like how we deliver care, but there are still blind spots. We have patients that don't have access to internet or don't have a smartphone. And so then like they weren't able to do e-visits for their prenatal visits or
and the pandemic has not hit all the groups equally. That's the other thing. You see huge disparities in terms of how COVID impacted people.
And so I think I just saw a lot of like little news sound bites about it. The CDC had released updated statistics on maternal mortality in February, and then they must have released something else. I need to go back and look. But everybody's talking about it now. COVID-19 only just made it worse. Maternal mortality was worse. And for Black patients, it was like 33% higher than everybody else. Unfortunately, COVID did exactly what it did in other domains, in that those who were the most vulnerable beforehand also bore the burden of the terrible outcomes after. And we're still dealing with it. I do think that medical education got more innovative and some care delivery things got more innovative, but there's still things that we're missing and blind spots that we have. And COVID only highlighted and escalated the problems that were already there.
And I think we're going to keep finding how the disparities with COVID itself is going to be like perpetually influencing things down the road too.
Yeah, for sure.
Well, and you mentioned earlier, I mean, all of the controversy right now about again, the made up term of critical race theory and acting like it's in everything, but you think about what you talked about, how in med school and your education, there wasn't really a focus on historical inequities and disparities. And like, in my mind, like to think that we were maybe moving that direction, but maybe now in a lot of states, we're going to move the other way and like not even be teaching the next generation of people that this is such a real problem in healthcare.
It's so frustrating. At Indiana University, where I am now, they absolutely have been committed to teaching it. And I was actually a medical student there before I left for like residency and fellowship. And we did not have the courses that they have now focused on health equity back when I graduated in 2014. And so things are changing for the better. Unfortunately, I think it's very state dependent and what your state values as important. But there's opportunity to do better. And hopefully we can change hearts and minds and make it more generalizable and not just dependent on where you live, that you get that education, but true history.
And I think we'll get into it a little bit in our short snack later this week, but it's just, sometimes it feels like we're going backwards, you know? So it can be really hard, to say the least, you know, when you see so many good things that we could be doing and we should be doing and should have done a long time ago, but now it's just like, where do we even go from here? Because some places are going backwards and some people are wanting to take it forward, and it's just so divided.
And I guess to make it a little bit less depressing to end on for our listeners, if you are, you know, a person of color and you're listening to this and you're trying to get pregnant, like what are steps you can take on a personal level? How can you advocate for yourself? How can you kind of have the best experience with the healthcare system that you can, knowing that you're not going to be able to like reverse all of these big issues?
I always tell everybody, if you're planning a pregnancy in the future, now's the time to optimize your health. So find out what your history is. Sometimes I have patients meet me for the first time and I'm like, do you know why your doctor sent you to see me as the high risk physician? They're like, no, I have a high risk pregnancy. And so knowing your history. So if you have high blood pressure or diabetes or thyroid disease, those are just some of the common things that we see patients for. Obesity, so a BMI of 40 or more, it can put you in that high risk pregnancy category. So thinking about just your history medically and the care you may or may have not received. A lot of times pregnancy is the first time that people are interfacing with the healthcare system, but I encourage you all to find a primary care doctor and just like tune yourself up, see if there's anything that needs to be addressed before the positive pregnancy test, just because this is the best time. Other things, taking a prenatal vitamin. So if you are a future pregnant person or planning to get pregnant, taking a prenatal vitamin with folic acid is really important because brain development starts to happen before the positive pregnancy test is even able to be detected. And so folic acid is going to be one of the things to make sure that there's normal spinal cord and brain development. And so you can start that now. I always tell people, stop smoking altogether, limit alcohol use, and then just rounded diet, exercise, 30 minutes of like cardiovascular activity a day. All of those things can help. And then I always just want to make sure people know when to seek care. Like if you're having trouble conceiving, so you guys probably talk about this all the time, but in obstetrics and gynecology, our general rule is that if you are less than 35 years old and you've been having regular intercourse for at least a year, and you have not achieved pregnancy, you should see a physician or someone who is in the medical field about your fertility. And then if you're over 35, 6 months, so much, much shorter time. And that's just, again, to optimize like the timing and making sure that everything is where it needs to be. It's so crazy. It's like one of my attendings used to say in residency, like, you know, when you're a teenager, like adults would make you think that like getting pregnant is so easy, but like it's actually
just look at each other. Yeah.
It's actually quite difficult and it's an inefficient process, but still like there are some time limits when you should seek some care, at least a second opinion.
And those time limits are assuming that you're having like regular cycles and things are ovulating each month. Because sometimes we see people who have PCOS and they barely even get a period, and to make them just wait this magical year makes no sense at all.
Yeah.
So.
Yeah, it's like you probably ovulated one time this last year. Yeah,
exactly.
Yeah. So anything that you have that might be a fertility related issue, endometriosis, fibroids, painful periods even sometimes can be helpful. And then, yeah, PCOS, things like that. If you have a known fertility thing, it's probably worth just talking to a fertility provider.
We love it when people come to see us. I feel like sometimes people feel like they're not allowed to come to the fertility clinic unless they've tried for that 6 months or tried for a year. But sometimes we bring people in, we can do some testing, we can kind of reassure them, okay, I don't see any real reason. I think we just want more time. And that makes that such a less stressful experience to then spend the next 6 months instead of like worrying you're missing something.
Exactly. And having a plan. I always think like, at least I think if I'm a patient, like I would love to know, okay, if this doesn't work, when do I call you? When do I show up? And I think it's great if you're established with somebody beforehand so that it's not this, because we all know like finding a new provider, like it can be so hard to get in. And so if you haven't conceived in a year and then it takes 3 to 6 months to get a new visit, like we're already behind the 8 ball. So absolutely. And then I was thinking like things specific to like Black birthing people. There's this app that is really cool called IRTH, IRTH, taking the B or the bias out of birth. And it's this directory of culturally sensitive healthcare providers by like zip code. And so it's new. And so there may not be a ton of resources like within your particular zip code, but it's worth trying. And like as people have their own birth experiences, encouraging them to fill that out, because it just helps you to like find a doctor that you feel like can partner with you or a prenatal provider. And then I always like to tell people like, you don't have to stay with your provider.
Yeah.
Yes, I know. I say that all the time.
You're not tied to them. Yeah.
If you are not happy, like I was saying before, like we spend so much money on healthcare and then like people are just supposed to like have these crappy experiences. Absolutely not.
Yeah, no.
It's like staying in a bad relationship. If you're like complaining to your friends all the time about how, oh, I don't really like this. It's like, just find a new one.
She really annoys me. Like, mm-hmm.
It sounds silly, but like even doing like a meet and greet as you like think about the doctor you want to see.
Yeah, I wish more places would do that. I know one hospital group in Seattle used to do them, and this is like way but then they like stopped doing them. Like that was such a good idea, just to have like a bunch of people from different clinics come, and you can literally do speed dating.
That's what they did on the east side too. You would walk into the little booth and just kind of at least get a little, because you do get a sense of at least people's personality and what's their philosophy when it comes to birth and care and
the practice and who am I actually going to see and all of those things, really important things. And it can be even just if you feel like it's just not a love connection, like, okay, they haven't done anything like outright making me uncomfortable, but like, I just don't jive with you kind of thing. That's totally fine. You want your OB provider to get you and know what your values are and know what you need.
Exactly.
Is there a place that you can look up and see like statistics for, like if you're going to a hospital, do they post their, rates of maternal mortality?
I do not know offhand. I feel like someone is doing this.
I think hospitals have to, but it's really hard to find. Yeah, they hide them, but I think I might have to scratch this, but I think there is like, they have to report certain things.
I mean, I know in school I had to do papers where I had to look into my community and find it, but you're right. It was not easy. You have to search vital records and like do all this. It's not like there's a nice consumer friendly, but I'm surprised no one's built like the app to make it consumer friendly now.
There's definitely not the Angie's list for, for hospitals.
No, and there needs to be, right? Like, I think that's part of the problem. Like the data is so hard to get and it's not transparent. I know that like C-section rates, one of the hospitals I trained at, they always had like a really good designation for a low C-section rate. And I think that's like publicly available, but I don't think it's like by race and ethnicity. I think it's just, you can compare hospital to hospital.
Yeah. And I know the website for March of Dimes dials it down to like the county level too for preterm birth. And you can really kind of see, just even within your local area, how you can see discrepancies in terms of, some of the common things that we worry about.
Yeah. Yeah.
Anything else that you want us to make sure to kind of pass on? I know you have so many things that you can talk about with us.
I feel like we hit all the high notes. Other good resources. So Loom, LOOM, HQ has an anti-racist birth plan that it's like a PDF you can print off, and it's like some good conversation starters. And then like there's a October 2020 article from the New York Times, and it's protecting your birth. And it's like a conversation guide for Black birthing people to have with their provider. So it would say things like, I saw a study that like Black patients weren't getting their pain treated. Like, how does your hospital treat pain? How do you guys eliminate biases? Because sometimes it's hard to bring that up, right? Especially because we know that 4% of physicians are Black, even less Black women. And so like, I get a lot of like, Dr. Johnson, how can I see you? I just want a Black doctor. But like, everybody can't see a Black doctor. So we need everybody to feel comfortable having these conversations and making patients feel like they can partner just as well.
That's great too, to have some sort of a template. Because I know when I was a labor and delivery nurse, like there was this one just epic birth plan someone brought in that was, I think, 4 pages long. And I had to Google some of the things they wanted us to not do. I was like, what is this? And we look it up and I was like, oh, we haven't done that in 30 years.
Yeah.
I had somebody that wanted the baby to be birthed into a basket. Like they brought a basket.
Oh my goodness.
Yeah. And I was like, that's a new one.
That is a new one. So I think, you do worry that just turning people loose is going to find a ton of things to worry about. And you don't have to necessarily list, I don't want blah, 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 blah. It's more like, here are the things that are really important to me. Here are the things I'm worried about, because you can't control everything. I think that is the challenge, that sometimes people, if they make such a rigid plan, and then when there's just no way things are going to go exactly according to plan. And so it's more important to have that. Yeah, like you said, that's a really great way of opening that up to make sure that you're at least at a place where the philosophy is consistent with what's important to you in your care.
Exactly.
And we can list those resources too. So if you send us to us afterwards, that'd be great to be able to link to things.
Yeah, I will.
I guess since you brought it up, like, are there places, like, I know there's been a lot of push to try and encourage more people of color to go into medicine, to go to like we would love to have a bigger generation of Black doctors. So
if you talk to different health profession schools, I think everybody, I won't say everybody, but a lot of them are trying to prioritize diversifying like the classes and going into more traditional, like thinking about the application in a less traditional way. And that as we think about structural racism and how it impacts other people who are trying to get to these like professions, there's a lot of gatekeeping in that, you might not have access to the more prestigious high schools that then lead to not as competitive colleges, which then may not prepare you as adequately for like the MCAT or these entrance exams. And so thinking about like a more whole person application and how we can get talent from underrepresented communities as well. And the pipeline program starting like exposure in elementary school and high school so that students are learning about professions. It's really humbling to be one of a few Black physicians, like even in my department. I don't know how many Black MFMs are in the state of Indiana. I think it's just me and one other person. That's not okay. Like that needs to change. And so I hope that even the visibility of what I do online, like all of that stuff helps to create recruitment and like interest in the field.
I think it's also great that you share your story too about having had a child first, because I feel like there's this sense that if you didn't go all the way straight through, then you're not going to be able to make it. And I mean, I know for me, when I went back to school, like the best people on program, people that had already been working for a while, lots of them had kids, and now they were kind of like refocused on what am I going to do next for my career? Because, we're realizing that people are living longer, healthier, longer. Like you can go back to school in your 40s and still be a really valuable person in kind of any different professional career, but it's not something that people think of as much. And it's a lot harder to do logistically because you are often having to juggle childcare and other responsibilities. So
for sure.
Well, it's awesome that you're so vocal about everything that you've done. And I'm sure you probably get asked to speak at all your kids' schools, right?
Oh my gosh. It's so funny. I tell people like my kids don't think I'm a big deal at all.
They don't think you're the Beyonce of MFM.
Well, then you must be doing something right. Yeah.
No. They don't want me to come speak. No.
They're just like, no, mom, stay. Just drop me off on the corner. I don't want to be seen.
Yeah. They're like, please do not come here and talk about health and anatomy. Please don't.
You're just mommy to them. You're not the Mrs. Mommy MD. They're not into that part.
Yeah, especially uteruses. They're like, please don't.
They don't want to know any of that. My son had he had a reproductive health unit last year. He's in 7th grade. And I was like, this is my time to shine.
You're like, can I help you study? No.
He's like, oh my gosh, please go away.
I know. Yeah. We already have some of those conversations with my kids are 6 and almost 4. And so they know like sperm and egg and all of that. And it's just like, oh, great. They're just going to be,
that's all right.
They're going to be so sick of me. Yes, Mom, I know.
I feel like our kids are always the ones that correct playground misconceptions though. Because I've definitely had a few where like they hear someone say like, no, that's not true. Like do blah, blah, blah. So I think that is.
It's important. They hear you, even if they pretend they don't.
Exactly.
Well, thank you so much for your time today. This has been just great. And I think it's such good content to push on. So, well, it's birth, right? We can talk about pushing.
It is birth.
Yes.
Such great content. And I really appreciate your time
Thank
today.
you so much.
Oh, thank you both.
Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review The Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.